I welcome everybody to this session of RSSDI Bytes. I'd like to first of all thank Dr. Purvi Chawla for organizing this on a regular basis. And this month we have had many programs on diabetes bites from different regions of the country because the RSSDI are doing a special campaign on walk, save the feet and keep walking campaign. For today's session, we'll be joined by Dr. A.K. Das in a couple of minutes. But we now have Dr. Basab Ghosh, who's a senior diabetologist from Tripura, Agartala, and Dr. A.K. Das will join us very soon. So, you know that diabetic foot is a very serious problem. So that's why RSSDA took up this campaign this year. We know that of all the amputations which happen in India, most of the amputations happen, lower limb amputations which happen in people with diabetes. Apart from road traffic accidents, I think diabetes mellitus is the commonest cause of amputations, lower limb amputations. And in a study which we did some years ago, we found that most of the amputations happen due to infection and on top of diabetic neuropathy. Peripheral artery disease is about 30%. But I think most of the common reasons for amputation in India is avoidable, which is neuropathy. And neuropathy is related to good control of diabetes. So, with this introduction, I'm going to ask Dr. Basab the first question. Um, what are the, neuropathy? I've talked about peripheral artery disease and neuropathy. What do you think are the other common foot problems which we encounter in people with diabetes? And are they particularly worse during the rainy season? Because now in many parts of the country there is rain. So, Dr. Basab, would you like to answer this question?
So, good evening. First of all, I would like to thanks RSSDI whole team and particularly Dr. Purvi for inviting in this forum. And it's my honor sharing screen with my teacher, Dr. Vijay Vishwanathan. Good evening, sir. And regarding your question that what are the complications we commonly encounter, the commonest, I believe, one of the commonest, I believe, is the numbness of foot. And numbness of foot is actually starting from the toes, then it goes up and it may go up to below knee, and that is a very common complaint patient are coming with us. And the second commonest might be painful neuropathy, painful complaint. Patients complain of different type of pain. They complain of burning sensation, they complain of pricking sensation, they complain of electric shock type sensation, then end bites sort of pain. So different fibers are involved for that mechanism or because of diabetic neuropathy, and they are complaining of different thing, different type of pain. So we should keep diabetic neuropathy in mind for whoever is practicing diabetes for that sort of complaint. We should not go for common analgesic type of tablet, which may spoil the kidney function. Kidney function may go down. And the thing third is fissures are very common in diabetes practice, and that follows dry skin. This is also another feature of diabetic autonomic neuropathy. And then edema is very common. Patients are coming with us for this thing, and they are concerned about cardiac and renal involvement. Then it is our job to exclude those and give emphasis on diabetic neuropathy. And if it is unilateral, most of the time it is because of diabetic neuropathy, that edema. Then corn and callus is very, very important. And corn and callus are nothing but they behave like a foreign body for the foot. And underlying there is definitely there is infections are there. So if sugar is not under control, for any time it can flare up as a acute foot infection. So that has to be taken care of properly, corn and callus. Then claudication is another very important. Patients complain, previously I used to walk a long distance, but now if I start walking, I get pain in my calf muscle. So that because of peripheral vascular disease. So that sort of thing should be in our mind. And another I should not miss, that is a swelling with redness. Swelling with redness, many times patients avoid. So whenever we are doing the examination, that is a take off shoes, I believe is the first thing for any diabetic patient, for the clinician we are doing. Then we can observe for even in minor inspection that swelling with redness, and that might be because of underlying cellulitis. So those are the things that we commonly see in our practice regarding diabetes patient. And your second question is whether it is more in rainy season. I don't believe there is any study. You might be knowing better regarding the studies, but I don't believe any study regarding this thing. But in winter session, neuropathy symptom goes up. So, and as in rainy season, there is a damp climate and temperature is down, so might be neuropathy symptoms are showing up. But I have not seen any papers, sir, for that.
Yeah, thanks, Dr. Basab. Talking about the rainy season, do you think that intertrigo, that is tinea pedis, is more common, especially when they walk barefoot? In our state, many people walk barefoot. So do
Yeah,
you think that? So do
that
you
angle
think?
I missed, Sarich. Yeah, the tinea infection may go up because of rainy season, and because then yes, that may increase during rainy season. But directly painful neuropathy or numbness or swelling, those may not be there. But yes, we should keep in mind the tinea infection. That definitely is a factor for rainy season. A very good point, sir. Learning for me.
Sociocultural sociocultural practices are very common, reason for foot infection in India.
Sir.
Especially in my state, many people walk barefoot. So I think walking barefoot, walking the rainwater, because the drainage system is not that good in India. So when it rains, water accumulates in the road and outside the home, inside the home. So they have to literally walk, wade through water. And so I think tinea pedis sociocultural practices play a very important role
Yes.
to play in the development of diabetic foot infection on top of neuropathy. So
Yes,
I
sir.
think
That's why wherever patients are coming in the first visit, I always emphasis on you should not walk barefoot, because many a time you must have noticed in your long practice that they're even morning walk time they're doing in barefoot. So what psychology or what pathology or what sort of thing is working on that, I don't know. But people are practicing it, and temple visit is a very common thing. Injury is there. So barefoot is definitely causing tinea infection in rainy season. That should be in our mind. Keep in our mind.
I welcome Professor A.K. Das to
Good
this
evening, sir.
diabetes class.
Good evening,
And
good evening, good evening. I was just had I didn't have that connection for some time. That's why I couldn't join. I'm very sorry. So
so the
so
first
I
question
think
I asked Dr.
yeah,
Basab Ghosh from Agartala
yeah.
was during rainy season, do you feel tinea pedis and fungal infections are common? So I think he was saying that, yeah, during rainy season, people do get fungal infections between the toes and so on. So that's what we were just discussing. Uh,
Vijay, I just wanted to ask you very important issues. Vijay, can you tell us normally how many amputations do take place in the country or in a country like India? How many
yeah.
amputations do you think take place in our country?
So I think amputation registry is lacking in India. We do not have a good amputation registry. But I was just telling Dr. Ghosh before you came, sir, that
Uh,
we do not have the numbers. The numbers from the IDF say that every 30 seconds is amputation happening somewhere in the world.
yeah,
Now, having said that, I would say about 10%, 10%, this is just a rough figure,
yeah,
about 10% of people with diabetes will undergo some form of amputation during their lifetime in India.
yeah.
About 10%. It could be even a minor amputation. So,
And
late presentation, about 10% of the people with diabetes. So, if you take India's number as 70 million or 80 million people, 10% is a huge number.
Huge number.
yeah, and
Your
and and Dr.
your
Bashav,
video,
I just wanted to know that what are the reasons why non-traumatic amputations in our country is so high? They say about non-traumatic amputations are about 80%. Why it is so high? And
Yes,
what are
sir.
the reasons for the
Yes, sir.
non-traumatic amputation?
Sir, actually, in other than accidental amputation, diabetes is the second cause of amputation whole over world. And in our region, it's basically because of neuropathy. Neuropathy is the major cause of amputation in Southeast Asia, including India. And add on this is peripheral vascular disease. So from the very first day of patients coming to the clinics, so we must concentrate on foot examination. Take off shoes should be the first message to any doctor whoever is practicing diabetes. So and then we need to check the minimum screening we should do with the tuning might be in our later discussion, those things will come. So we'll see for diabetic neuropathy whether it is there or not, then peripheral sensations are there or not, then peripheral pulsations there or not. So those are the factors that are causing traumatic amputation in India very high.
I think, Basha, you said something which is very important. I think Professor Vijay is the president, a great rare honor for our country. He's the president of the
Diabetic foot.
world's diabetic foot group. And Vijay would remember that about 3 years back, when people asked Paul Brandt that what is your message to the world about the diabetic foot? You remember, Vijay? He didn't say any instrumentation, any new investigation. He said, just ask the patient, take out these shoes, take out these socks, have a look at the foot. Basab, you're absolutely prophetic. You said that. But what struck me after you gave your answer, Basab, I like Vijay to highlight this particular point that having amputation on a ischemic foot is possibly acceptable. I don't say it is acceptable at the long, but having an amputation in neuropathic foot, to my mind, is a shame. I remember
It's a
these
shame.
studies by Professor Vijay Vishwanathan, who is here with us today, and also by Dr. Sharat Pense have shown that now ischemic foot ulcers are gradually increasing. But even the neuropathic ulcer, I like the audience to take part of this message that, the neuropathic foot ulcer must heal by rest on antibiotics. But having an amputation neuropathic foot is actually a shame. I like the world president to give a small message on this to our countrymen. Vijay,
So thank you, sir. So I think the main point is the late referral or late presentation. So when you have neuropathy, when you develop an infection, you don't know about it, and patients will delay and take all native medicine, and they will come very late to the doctor. So that is the commonest cause for amputation in our country: late presentation to the doctor or surgeon, whoever it may be. So I think the main message is, if you have loss of sensations, you should test your feet, have it examined every year. Number one. Number two is, when you get a small lesion, consult, don't delay. You go immediately to the doctor. It might be a small bleb, but you don't know how serious it is. So you go to your physician or your surgeon and show them the lesion and take appropriate treatment. So, as you said, sir, a neuropathy person should never get an amputation. But in India, neuropathy people are getting amputation because when they get a lesion, they do not go immediately to the doctor. They go when the infection spreads along the tendons to the
yeah,
entire foot or to the knee, and then they
very
go.
important.
So that's too late.
And I'll just add
Absolutely.
on, sir. I'll just add on one
Yeah, yes,
point.
Basab.
And
Yes, Basab.
sir,
Yes, Basab.
there is lack of coordination in India. We do not have one roof conception. Like a diabetologist, we cannot communicate with the surgeon many of the times. So surgeon think in their line, we think in our line. So there is lack of communication might be one of the biggest factor for amputation up to that extent, sir.
Yeah, I think Basab, you're correct. What Vijay and others, Vijay with his friend from Zambia and others, they have spoke about is a teamwork. Diabetic foot is a teamwork. It must be a physician diabetologist who, to my mind, is the leader of the team. We have a surgeon, we have an educator, we have chiropodist, and we'll orthopedic surgeon. I'll come to a minute, but Basab, your point is very well taken. That wherever you are, whether I'm in Pondicherry, I've asked seven of my doctors have joined Vijay, and I must tell you that even if we do not have facility for a full team, we can take the help of these surgeons, orthopedic surgeons, the radiologists, interventional radiologists, to see that we have a team, however small it may be, however difficult it may be, then that teamwork is absolutely important. Vijay, I have another question for you. Then I'll pass on to Dr. Basab. Vijay, you have popularized something which is very very important. You had given a X second foot examination. I'm not taking with the 30-second or 180-second, but you had said that with the infinitesimally small time, one can examine the foot and get an answer. I like that concept that you gave some time back. Absolutely, I mean, greatly like that thing. I think, Vijay, can you kindly share that concept very briefly?
Yeah. So the 2-minute foot examination given by David Armstrong and Andrew Bolton, they were the two authors of that article. And that's the same thing which we used in the RSSDI campaign, Save the Feet and Keep Walking campaign. So it entails asking some basic questions. Have you had an amputation before? Have you had an ulcer before? And then examine with a monofilament. So that's what we have done in this campaign, RSDA campaign, which is now examined more than 40,000 people across India. So the 2-minute foot examination, which is available in the internet from David Armstrong and Andrew Bolton and colleagues. So it is very simple, only asking a few questions and examination, looking at the feet, inspection, question answers, and examination. It takes only 2 minutes. And if you do spend 2 minutes on the foot, I think it takes more than 2 minutes to even tie a blood pressure cuff. But
Yeah, absolutely, absolutely
examine,
correct. Yeah, yeah.
examine the
I think very prophetic answer. There is no excuse, Bashav. What I think all of us, me, Bashav, and Vijay, subscribe to the view. There is no excuse that I have no time. I mean, correct.
Absolutely, sir.
You
Absolutely, sir.
nobody can say I don't have 2 minutes to examine the diabetic foot. I think this is a great message that we have taken in this Save the Feet campaign of RSSDI, and this must dive deep into the minds of the people. I just want to make a concept very clear, and it is for the people who are attending. A lot of doctors have joined this program, Basab and Vijay. I just want to know from you what we call quote unquote foot at risk, quote unquote foot at risk. So, Basa, would you like to explain what you mean by foot at risk?
Foot at risk is, sir, those who are having diabetic patient. The day they are diagnosed with diabetes, this is at risk of foot infection. So from the very first visit to the doctor, we need to check the neuropathy uh, examination, then peripheral pulsation examination. Those are the things should be checked. Then again, as I already said, then whether there is edema not, whether there is callus, foreign bodies are there, callus, and then what is called this corn and calluses are there or not, then claudication history is there or not. So those are the points which will highlight the high risk food for any diabetic patient, sir.
Yeah, I think we're correct. And in this campaign, Basam, we have taken the view that those who cannot feel the 10 gram monofilament when it buckles, when they cannot see 10 milligram monofilament when it buckles, that means they're the foot at risk. Absolutely, it's just correct that there's a deformed feet, a hamarto, a deformed foot, having a callus. You cannot be callous about a callus. And you having a kern, having the callus is only hiding the ulcer below it. Absolutely
Sure.
correct. But simply we have driven this message in this campaign that just take a 10-gram monofilament. Vijay would not agree that the same monofilament we can use. Vijay, there's a practice which is of high level. Vijay, also I listened from you that you want to have a proper monofilament which is from the what is the institute in America which gave that monofilament concept from
Car-
yeah,
Carville Leprosy
yeah,
Center.
parallel. We also in India have the monofilament which are
Siemens
available
Winston
for Sam Swinston monofilament for about
5.07
very
is
good
5.07 we are using in
5
India, sir.
years. Yeah, and
But
we
sir,
say that
but sir,
if that
one point I would
yeah,
like to say. This is the
yeah,
monofilament what we are
yes,
using. I just kept
yes,
one for the
yes, yes, yeah,
thing.
yeah,
But
yeah,
if this is not easily available for the practitioner, So if it is not usually available, with a tuning fork 128 hertz, it
Yeah,
is written here. So that
yeah,
simple tuning fork and pulsation of the peripheral pulse, that is enough, I believe. Dr. Vijay
yeah.
Vishwanathan will agree
No,
with me.
I mean,
This
I cannot agree more, Basab, what you have said. And but
this the
classically,
vibrations sensation, then even temperature we can check with this, and then pulsations. That is enough, I
yeah.
believe, sir.
Yeah, but in our campaign, Basab, you're absolutely correct. We say we even the palpation of the foot pulse is almost equivalent to doing a ABI, ankle brachial index. Doctor friends in the
Sir.
audience are understanding that. Yeah, only sometime MAC, medial arterial calcification. When the blood vessel gets calcified, you may go wrong. Otherwise, palpable foot pulse, as Basab said, is good enough. Doing a tuning fork, it will give you the large fiber function, and the opposite side of it, a cold sensation give you the small fiber function.
No,
Absolutely correct.
absolutely.
Classically in our campaign, we have said with Basab that this particular monofilament, we have somebody has supported this program, and we have tried to, in almost 43,000 people, we have tried to make this concept that at least what you said is absolutely correct. One should do palpative foot pulse, one should do the tuning fork vibration sensation, and one must look for the last fiber. But at least this 10 gram monofilament 5.07, and that is bulking, that is just bending and not able to feel that is
Yes,
definitely a
sir.
that's the greatest concern. I just want to know from Vijay, what do you think, apart from the simple foot ulcers, we also have deformed foot in our country. Sometime back, we believe that we do not have a deformed foot which is found elsewhere, like a sarco foot, which said it is doesn't exist in India. But you and others and Bashav and others have given the concept that is a wrong myth. We also have a deformed foot. We also have a autonomically advanced diabetic foot with a bag of bones and all that. And Ed was there in IDEC meeting, Vijay. Ed Jude Ed came down to Pune day for yesterday, and he spoke about his experience of the Charco. I'd like to know first from you, Bhaskar, your experience about the Charco, and in simple words, some lesson to the countrymen about how do we take forward the looking for the Charco food. I'll come to other food in a minute. Purvi, please allow us. I joined about 8-9 minutes late. Please allow us the time because my net was down. Even today, I'm not putting my video on. Please bear with me. The heavy rains. Please bear with us. Purvi, give us 8-9 minutes time extra. Yes, Vijay.
So, it's a very good question, sir. But before I talk about
Yeah.
Charcot, let me tell you, let us discuss that due to diabetic neuropathy and wasting of the intrinsic muscles of the foot,
Mhm.
most of the people have a telltale evidence of neuropathy, as evidenced by clawing of the toes. The toes will not be straight, it will be bent. So that is a very, very important risk factor for getting ulcers in the calluses and ulcers
tip,
in the
tip,
tip of
tip
the
in the
foot.
tip of the phalanges. Yeah.
And the Charcot foot in India usually follows one, a surgery where you remove the big toe or whatever, or some trauma. That is what the Indian experience showed. There should be one toe which is removed and the biomechanics changes,
Mhm.
or it should be some trauma, some accident, which caused an injury to the thing. So the two common causes for Charcot foot in India
Yeah.
are
Yeah.
trauma and
Yeah.
losing a toe, cutting off a toe, and not giving a filler to fill the amputated toe. So faulty
Yeah.
biomechanics. So faulty biomechanics and trauma are the two important causes for Charcot foot. So when do you
Incomplete
suspect
surgery.
Charcot? Yeah, and when do you suspect Charcot is when you have unilateral swelling. If you
Mhm.
have bilateral swelling, it's easy. It could be kidney disease or pyoglotism, whatever,
Yeah.
or
It can
amyloid
be.
or nifedipine. But if you have unilateral swelling, swelling only on one foot, and the patient has diabetic neuropathy, you should rule out Charcot foot unless proved otherwise.
Yeah.
He has
Yeah.
unless proved otherwise. So I
Yeah.
think a Charcot foot is proven or not proven by an X-ray and all that. So if you have neuropathy and unilateral swelling, it is sharper food only unless you prove it otherwise. So that's the important message I would like to
Great.
pass.
I think the great message you have given that it can occur in our country with the advances in the longevity of our persons with diabetic. It can occur. One can be alive to this possibility if somebody has severe neuropathy with unilateral swelling and unilateral bone fracture and things like that. And there are today ways and means available to fix that problem. Basha, what do you think? What is the reason in India that we have now increasing of the ischemic diabetic foot? Why we say that compared to yesterday? Today it is slowly increasing in number.
So there's a
Is
lifestyle.
it longevity?
Lifestyle. So lifestyle is a commonest factor here, and smoking is one of the highest risk factor for this.
Absolutely,
Sir.
absolutely, absolutely. Smoking
So
and lifestyle,
diabetes and
and also
smoking
people,
cannot go
yeah,
together.
yeah, people living longer, and that's one of the reasons why probably we're getting ischemic foot also. Now, Vijay, I just want to know from you that is there any advances in preventing neuropathy in a diabetic foot? I mean, I would like you to touch upon the simple messages for our countrymen, starting from the control of blood glucose to whatever you want to educate them about. This is about how do we prevent diabetic neuropathic ulcer, neuropathic foot, not ulcer even, diabetic neuropathy in our population, which is the forerunner of the maximum diabetic neuropathic foot.
I think the most important factor, as you said, sir, is glycemic control.
Mm,
And we have now data to show that the glycemic control in the pre-diabetes stage
mm,
determines neuropathy. So
mm.
we have published a data that 19.7% of impaired glucose tolerance patients have neuropathy. So neuropathy should prevention should start even before the diagnosis of diabetes, during the stage of pre-diabetes. So it's a continuum. So we don't know at what HbA1c or what blood sugar the neuropathy sets in. Because
Cutoff we do not know.
HbA1c in pre-diabetes is something like 6.2, 6.1. But at that stage, many people have neuropathy. So neuropathy prevention should start even before diabetes is diagnosed, number one.
Yeah, I think.
Number two, there are known risk factors for neuropathy. You said about smoking is also an important factor for neuropathy. And apart from that, lipids have been shown, especially LDL cholesterol, has been shown to have a close correlation. Low HDL, high LDL has been shown to be an important factor. So we are collaborating with Dr. Eva Feldman, who was the president of the American Neurological
Yeah,
Association.
he's one of the famous men. Friedman is Friedman. He's
So
great guy
we are collaborating with her to
with her.
yeah to look at the lipidomics, and metabolomics in neuropathy in pre-diabetes. So I think the raised HDL, smoking, diabetes, there are multiple factors.
Even alcohol, sir,
Alcohol,
Yeah, yeah,
which are
absolutely, absolutely. Yeah, I
for
think, I think,
neuropathy.
I think, Vijay, what you said is correct. I of late reviewed this topic when I gave a topic in Mohn's meeting. I said the neuropathy, what is new? And Vasab, what Vijay is saying that we today we have data to say that in pre-diabetes one can find. Of course, this is not for the. I'm not going to sound very high words, but there is a test called confocal microscopy, corneal confocal microscopy, and it has been shown in the pre-diabetes stage. One can show the fibers being separated, becoming sparse. So what Vijay said is very correct, that we should try to catch them early, catch them young. That is the and also it is possibly a complete diabetes management which will take care of
Absolutely.
the diabetes neuropathy and upcoming diabetes neuropathy also. Basab, I would like you to speak one or two words. How do we take care of the painful diabetic neuropathic foot?
Sir, So before coming to that point, I just
Yeah,
as Dr. Vijay sir said about pre-diabetes, that pre-diabetes is actually neglected in our practice, day-to-day practice. We just say the patient, you control, you do some exercise or do your diet, everything will be done. So actually, the screening should start right from dysglycemic level of pre-diabetes. Then only we can prevent all the complications of diabetes. And regarding your question, sir, as you said, sir, can you just repeat this?
yeah. I just want to know you one or two points regarding taking care of the pain in diabetic
Yeah,
neuropathy.
sir. Yes. Sorry for the interruption. So
Yeah, yeah,
pain is a very commonest thing in our practice, and we are approaching with the pregabalin nowadays is very popular among us, and duloxetine also doing the fine job. So
got
combination
it.
of pregabalin and duloxetine is the master stroke for diabetic painful neuropathy, sir.
Absolutely, absolutely. And also there is also some truth. I don't know whether Vijay will agree with me or not. Like GLA, there is some truth that GLA and some of the supplement that we give, they also make some
Alpha lipoic
contribution.
acid.
Especially
Going
Dan
with the-
Ziegler, especially Dan Ziegler from Dusseldorf has shown
Yeah,
that alpha lipoic acid is a very strong antioxidant. And in the evolution of diabetic neuropathy, he has shown that alpha lipoic acid is a very important antioxidant. And
yeah,
he has shown that oxidative stress might be important. So, what Professor Das said is absolutely true. You have to think of vitamin D deficiency,
yeah,
thyroid deficiency, and also
yeah,
lack of GLA or ALA or
yeah.
whatever. So I think
I
it's very
remember Vijay some time back. You remember Jamal? Jamal was doing a lot of work on GLA in the United Kingdom. You remember Jamal, Vijay?
yeah, yes.
And these were the earlier investigations, Basab, which showed that it is useful, and today it has stood the test of time. There's a question by Dr. Rajini Bhomik. I think the question has been posted in the question box. Very, very interesting question. I think any one of you can take the question. Uh, the
If I
question
can,
is:
so
do
yeah,
the patients of the Charcot, do they get PAD? PAD standing for peripheral arterial disease in diabetes. Yes,
yeah,
any one of
Vijay,
you, Vijay?
Charcot
Vijay
foot is an
sir.
extreme form of neuropathy, and neuropathy is associated with peripheral artery disease. We call it neuroischemic wounds or whatever. But Charcot foot is associated with increased arteriovenous anastomosis, collaterals, and so on. So, peripheral artery disease is quite uncommon in people with established Charcot foot because of the arteriovenous shunting, and there is enough blood flow. The problem is increased blood flow to the foot in
Yeah,
Charcot foot.
yeah, I think to clearest distinction, Dr. Bhomik, between the neuropathic and the ischemic foot is one of the differences the ankle brachial index. Ankle brachial index is high in neuropathic foot, as Vijay and Basab have pointed out. It is low, zero point 0.6, zero point 0.8, zero point 0.7, depending on the degree of ischemia in a ischemic foot. And the Charcot being an advanced neuropathic foot, it is a worn foot. It is a highly circulating foot which takes away the bone and the minerals from the bone. So there is no PAD in that condition. Now,
Mostly
last,
calcified vessels are there, in fact, rather.
yeah, yeah, correct, correct. Before we close, Vijay, I have got three questions to ask. Purvi, thank you very much for being tolerant to the time. Vijay, I just want to know the role of education. I mean, that is paramount, no doubt. But what type of things our doctors who are having solo practice or having practice with one assistant or no assistant, how will you tell them to carry out the education about diabetic foot?
So I think it's very simple, sir. I think one thing which doctors can do, even if they have only one receptionist,
Yeah,
is just tell them to examine the foot every day. One.
mhm,
Second
yeah,
is ask them to come for a foot exam once a year. So foot exam, foot exam, self examination, and the doctor examining for neuropathy and LOPS, loss of protective sensation. So these are two things which are free because to touch the feet and do a monofilament, you don't have to charge them. And
yeah,
the patient examining the foot with a magnifying glass or or somebody else
Okay.
looks at it. It's also free. You don't have to pay anybody. So I think the two things which I would recommend strongly in private practice with somebody who doesn't have facilities is also foot examination by the doctor and self-examination by the patient. Two things which
Correct.
will
Absolutely.
Correct.
help.
I
Absolutely.
think I have only last question to ask. I can see Puri being in the in the machine now. Puri, your interest in the diabetes fights in general and diabetic foot in particular has been infectious. I want to ask Basab the last question. So, will you define the role of the diabetic footwear? Very briefly in the Indian context. I heard that when I joined about 7 8 minutes late, you were speaking about people going to religious places barefoot, and you pointed out, but in little greater detail, some take home regarding the diabetic footwear, preventing diabetic foot also.
Thank you, sir. Actually, my take-home message is barefoot is never done for any diabetic patient from day one, even for pre-diabetics. And regarding the footwear, it's very, very important. Even whatever footwear we are using, we should teach the diabetic patient to check it every day while they're wearing it, because there might be some foreign body inside the shoes, there might be some insect inside the shoes that can cause insect bite or some foreign body impression problem because of neuropathy. And regarding footwear, the easiest thing I tell my patient, you buy one size bigger. And second thing I tell, never wear footwear with thong. Any footwear with thong is a criminal for the diabetic patient for further deformities. So, and footwear, regarding footwear, that insole should be very soft. I teach them like this, that whenever you are buying a foot, you check the insole whether it is soft or not. So, soft insole, roomy toes, and the wider toe box, and the inner side of the shoes, and proper sole, and those are the factors. And whenever buying shoes, the patient should not go in the evening. It's better patient goes in the early part of the day, because in the later part of the day there might be some swelling, so they cannot buy their original shoe. So those are the points I check. And
Thank
in
you,
fact, other
Basab.
than shoes, sir, socks is also very important. They should wear cotton socks, and that should not tighten very tough. So those are the points,
Thank
sir,
you.
common points.
Thank you. Thank you very much, dear friends. We have another question which I'll take the liberty of answering. There are a lot of data saying that duloxetine is useful in diabetic neuropathic pain, either singly or in combination with pregabalin. So there are enough data. We are using it left, right, and the middle. And even in the data, even the new guideline that came out about 4 years back. Remember, which is the guideline? Duloxetine has been used for pre-diabetic neuropathy. Dear friends. A great evening today, and if the efforts of Vijay and Basav has gone deep to the practice, my dear friends, colleagues who are present here, and if we have made a little bit of practice change, little bit of practice essential, that take care of the issue patient patient put as their face. You make them the concept we have to take care of the foot as their face, and then you can even start examining from the foot. Never forget that diabetic foot is important, and by this simple tenacity of purpose, by examination, education, interest in preventing diabetic foot, many parts of the country, the diabetic foot amputation have come down, except for the ischemic foot. We hope and pray that the efforts of Purvi and her tribe will not go in vain, and we'll be able to conquer diabetic foot in time to come. With this hope and with apologies for saying about 12 minutes late, I hand over the forum to Purvi to close it.
And I
My
just say,
thanks to
and
Basav and thanks to Vijay. Vijay, yes. Vijay, please take.
so I'd like to
Vijay.
first of all thank RSSDI for taking up this mega campaign
Absolutely.
of 1 month, and we have extended it by 1 week. But we would definitely like some states to screen more patients and help us to reach our target of 50,000 patients by August 17th. So we would like some states to improve their.
Yeah, I think that's a great message. I forgot to ask that question. Vijay, which are the states lacking behind?
So I would like I would not like to mention the names,
Okay,
but
I
I
think that's okay. You are a Vijay is a gentleman. I am not. So but the bottom line is that we have to do a lot, and I agree with you. And we have to at least achieve that number. And it is very essential that this examination should percolate in the length and breadth of the country, not in one part of the country. That's why we want to do the pan Indian phenomenon. Thank you, Vijay. Thank you, Basab. Over to Purvi for her masterly comments and then closing it.
Sir, there cannot be any more masterly comments after the prophetic messages that you, Vishwanathan sir, and Dr. Ghosh have given. All I can do is just thank you for the efforts for simplifying messages so much for not only our patients but also physicians joining in, and all the key messages. We really, I think one thing that has happened in the last month is that diabetic foot disease has really come to the fore of everybody's notice, and I think it rightfully deserves that place. It's a preventable, dreaded complication, so let's do our bit. And with this, I also join in the plea to get more physicians involved, and those already registered, we really request you to enter all the data that you collect after you examine the patients. It's extremely simple. It's just 2 minutes for the examination, as Dr. Vishwanathan sir has explained. It's the importance of it has been very well emphasized by Professor Dr. Das sir, who has joined in at very short notice, but we are extremely grateful for his presence today. And Dr. Ghosh has also given us very simple practical tips that patients can follow also to prevent these kind of problems in the future. So we urge you all to take an active interest. We have a week more, so let's just do it. So with that,
Thank you very much, Purvi.
Thanks a
And the
lot.
message that my friend used to give, Charaibati, Charaibati, Charaibati. That means we must see that our diabetic patients, our persons with diabetes, keep on walking, walking, and walking. And that is very important. Charaibati, Charaibati, Charaibati. Thank you, Purvi.
absolutely. And on that wonderful note, I thank you all again on behalf of Dr. Vasant Kumar sir, our president,
Yes,
Dr. Sanjay Agarwal sir, and the entire executive committee. Our vice president is right here, and
yes,
our
yes.
patron is also here, and also the social media team for doing this today. Thank you so
Thank you.
much.
Thank you. Thank you. Bye bye. Bye bye. Bye bye. Bye bye. Thank you, Basha. Thank you.